Chairperson Hansen, and members of the Health and Human Services Committee, thank you for the time to speak with you today. My name is Dr. Elizabeth, Elizabeth Constance, Constance. I am double board certified in obstetrics and gynecology and reproductive endocrinology. I am speaking to you today on behalf of the American College of Obstetricians and Gynecologists, which is the governing body that sets best practice guidelines for all OBGYN physicians and in opposition to LB 574. As a reproductive endocrinologist, I have 3 years of specialized training in the management of reproductive hormones and have published research on the reproductive effects of gender-affirming hormone therapy, which makes me exquisitely qualified to testify today on the use and safety of the medical treatments being targeted in this bill. The American College of Obstetricians and Gynecologists first published a practice guideline for OBGYN physicians relating to healthcare for transgender and gender-diverse individuals in 2011. This document was most recently updated in March of 2021 and states that the majority of medications used for gender transition are common and can be safely prescribed by a wide variety of healthcare professionals with appropriate training and education. Puberty blockers have been used since their development in the early 1980s to stop puberty in children who are going through it too early. As such, we have over 40 years now of widely accepted data that these medications are safe in children. In fact, they have been FDA approved for use in children since 1993. From this data, we know that puberty blockers are reversible once they are stopped, and there are no documented long-term negative effects. Short-term effects on bone development are temporary and reversible once puberty resumes, whether that puberty is spontaneous or medically induced. These medications are critical in the treatment of transgender teens as they allow for puberty to be paused while the individual grows and matures, buying them and their family precious time to make decisions about whether or not additional treatment is desired without feeling rushed into a decision. Additionally, inducing puberty by prescribing hormones such as estrogen or testosterone is also well-established therapy. We use these medications commonly for children who are born with ovaries or testicles that don't produce their own hormones. Many of these conditions are specifically excluded in this bill, which suggests that the author of the bill does not believe them to be harmful for all kids. So I ask you, if we can agree that these treatments are safe and effective for the kids with the excluded medical conditions outlined in this bill, why single out transgender youth and withhold safe and effective medical treatments from them? How, when we know that access to gender-affirming medical care has been shown to decrease symptoms of moderate to severe depression by up to 60% and decrease suicidality by up to 73% in transgender kids, can we in good conscience withhold safe, effective, and life-saving treatment from them? I urge you to stand with widely accepted, established medical guidelines and not advance LB 574 out of committee. Thank you, and I'd be happy to answer any questions.
Thank you for your testimony. Are there any questions from the committee? Yes, Senator Reedy.
We compete at times as to who gets their hand up first. Thank you for being here. I initially said to myself, why is an OBGYN here? And then when you said the word hormone, then I kind of registered with me, so thank you. Is it your position to fully support parental engagement in the discussion with youth? We hear stories, don't know whether they're all true or not true, that at times educators might take it upon themselves to embrace children, and so that's where it gets into a lot of the emotion.
Mm-hmm.
So
I'm not an educator.
But if you had a family that came to you and to talk about hormones.
Mm-hmm. In the context of providing medical care, the family is a huge part of that discussion from the very beginning. I have a lot of pediatrician colleagues who are here today as well. That's usually where that conversation starts, is with their family practice or their pediatrician. But it's a family discussion, and it's something the parents are very much involved with at every step of the way.
Yeah. And as a former hospital administrator, I can tell you, we wouldn't let anybody touch a patient at the risk of it being assault if you proceed forward without that. The other one, because you're a professional, and this one I'll probably ask other people to get their, about the frontal cortex development, which I asked before. I was saving that for an MD, but I got over anxious. But where do you think And what implication does this have on when surgery or medical or other more serious things other than counseling can come into the play?
Well, I think it's a fair question. I think we let teenagers make a lot of decisions. We let them drive vehicles. We let them choose career paths and where they go to college. We let people under the age of 25 get married and buy guns. So, if we're going to outlaw every adult decision for anyone under the age of 25, that's one thing. I think we could all agree that that's not logical. And so I think, with medical decisions, medical treatment in general, whether it's treatment of diabetes or cancer or gender affirming care, we institute an informed consent model, which means we talk to patients and for minors, patients and their families about the risks and benefits, and then we let the families make the decision that's best for them.
My response would be driving a car is significantly less life altering than having surgery. Some of these have parents of kids, I guess.
Yeah, I think young adults do a lot of things that have lifelong impacts on themselves and others.
I'm not sure they're comparable, but I'll give to my friend here.
Senator Kavanaugh.
Thank you. Thank you for yielding, Senator Rigby. Dr. Constance, thank you so much for being here. I have a couple of questions. The first is, we've heard a lot about studies, and one thing that, I don't know if you're the right person to answer this or not, but talking about control groups. I mean, when we do a study, we have a control group. And so I'm just kind of curious how that works when we're talking about gender affirming care. Maybe you could speak to that a little bit.
Yeah, absolutely. So anytime we do research in human subjects, so people, that research protocol that has to be approved by an institutional review board at whatever institution the researcher is at. So these IRBs read the research protocols, the planned treatment, the proposed control or lack thereof, and decide whether the research is ethical. Gender affirming care is such established medicine at this point in time that no institutional review board will approve a research study for transgender kids that has a control group. So it's like if we had a study about diabetes, you wouldn't take a group of type 1 diabetes and people with type 1 diabetes and give one group insulin and withhold insulin from the others because it's life-saving. And so this medicine has become in the medical establishment so well established that it is considered unethical to have a control group that does not have access to that care.
Thank you for that clarification. So we did hear, and I don't know if you were able to hear any of the testimony and support, there was quite a bit of testimony around the adverse effects of these puberty blockers or hormone therapies. And you stated that there is no documented long-term negative effects. And I know that your specialty is helping individuals build their families that are struggling with reproductive fertility. And so that being your area of expertise, and you saying this, and some of the things that we heard were concerns over infertility, I just wanted to give you the opportunity to maybe expound on that a little bit more, because I would say that was a theme that I felt was stated numerous times, and I don't want to diminish any of the previous testifiers and their own personal experiences, but I would like to hear your medical opinion on this.
So with puberty blockers specifically, they're immediately reversible. So this is why they're often used, because it puts puberty on pause. It gives families time to make decisions. If they decide to move forward with hormone therapy, they can do so. If they decide not to move forward with hormone therapy and they stop the puberty blockers, their natural puberty will immediately resume. We don't give these puberty blockers until puberty has actually already started. So we're not talking about young children. We're talking about teenagers at the beginning of puberty.
And so what I'm hearing is puberty blockers are not the same thing as hormone therapy?
Correct.
Okay. That's a big distinction I was not picking up on. Thank you.
Absolutely. Yeah. So the puberty blockers just stop puberty, put on pause. As soon as you stop them, natural puberty either continues, or you can start hormones for a gender affirming puberty.
Okay.
So the puberty blockers themselves are completely irreversible. There are no long-term negative effects of that.
Okay. Thank you. I feel like I'm asking for biology lessons. Sorry.
Any other questions? I might have one. Just to clarify one of the statements you made about we use these medications commonly for children who are born with ovaries and testicles that don't produce hormones. So you're giving them hormones to help facilitate that process to get that to work.
Correct. So there's a variety of conditions called differences of sexual development, where people are born with non-functioning gonads, so non-functioning ovaries or testicles that don't make hormones. And so then they have to be given hormones to go through puberty at the same time as their peers.
Okay. I think it might, just to play devil's advocate a little bit, I think there might be a little apples to oranges because you're giving them hormones, I'm assuming the ones that they're lacking to have them go in a certain direction. I think what we're talking about maybe pertaining to this bill is you're giving hormones to have them go the opposite direction.
The hormones themselves are the same. So the safety of the hormones is no different than if their body was not producing them or if their body's just not producing the correct ones.
Okay, just make sure I get this right. So if you have a young female who's not producing enough estrogen or progesterone, you give them that and it helps them kind of go through puberty because they're lacking those. That is just as safe as giving the same thing to a male to do the opposite.
Because we're talking about prepubertal children. So a prepubertal male still isn't making hormones, any kind of hormones. So you're giving the hormones to induce a particular puberty.
But I'm asking, are they just as safe?
Just as safe.
Okay, that's what I was wondering. Okay. Any other questions from the committee? All right, thank you for coming. Appreciate it.